Welcome to today's Pharmacy Innovators Podcast. I'm your host, Jim Jorgenson, and on today's show, we are heading north of the border. We're going to talk with Kevin McDonald and Sammu Dhaliwall from North West Telepharmacy. These guys are two pharmacy innovators who are bringing remote pharmacy services to hospitals and community programs across Canada. So welcome, Kevin and Sammu.
Thanks, Jim.
Since I'm sure most of our audience doesn't know you, can you give us some background on your careers and, how you got to Northwest Telepharmacy? And let's go Kevin first and then Sammu.
Sure. Well, glad to be here. I graduated from pharmacy in 1993 from University of Toronto and proceeded to do a residency at the Addiction Research Foundation in Toronto. That was a Northern Ontario boy to start with, and in the big city of Toronto for 6 years. It was great. But at that point, I was ready to get well away from Toronto and actually headed to far Northern Ontario to Moose Factory, worked there for a couple of years. And then, then came back, started doing some teaching hospitals in some cities, nothing as big as Toronto, but Ottawa and Kingston. And the opportunity came up to help provide services on a day-to-day basis for the Winnebago General Hospital in Moose Factory, where I'd worked right out of residency. And that's where telepharmacy was born. So it started out as a business through a local pharmacy in the area, which was acquired by the Northwest Company a couple of years later. So that's our history, 20 years of telepharmacy. So, Sammu.
Yes, I graduated about 10 years later from the same faculty of pharmacy at U of T in 2003. Did a hospital residency at a London Health Sciences and started working at a large community hospital, now probably almost like a teaching hospital in Mississauga at the Trillium Health Center. Worked there for 4 to 5 years while completing a doctorate of pharmacy from the School of Skaggs of Pharmacy at University of Colorado, and finished that in 2010. But I was, working in the emerge department and, really enjoying it. But I was starting to try to find different things to do and something different in the northern community. And so I met Kevin in 2008, heard about what he was doing, what his vision was of how he wanted to really get, pharmacists with teaching hospital background and be able to kind of spread that knowledge up north in small communities that don't get exposure to clinical pharmacists. And so jumped on the ship in 2008 and haven't looked back, and have been able to really help with innovation in different aspects of how pharmacy practice is delivered across Northern Canada.
Thanks. We've had the opportunity to partner with you guys on several Canadian projects. And other than the payer system, I think we find that overall the practice of pharmacy in the US and Canada is pretty similar. But any significant differences from your perspective outside of the payer system?
Yeah, you're certainly right. There's a lot of similarities between the two countries and the practice of hospital pharmacy. I think what we found back in 2004 when we started telepharmacy was just that Canada was quite a bit behind the US in terms of innovation and some of the accreditation requirements. So when we started there, there was fewer than 4% of hospitals that had their pharmacies or a pharmacist available 24/7, other than maybe basic on-call services for the largest places. We found that, bedside med verification and CPOE, while it was booming in growth in the United States, we had 2 hospitals in Canada that were at that level. And part of it was the accreditation standards in Canada. If you couldn't get a pharmacist in small town Canada, that might be a 4-hour drive from, your next hospital, how are you going to enforce a 24/7 rule for hospital pharmacies? So, hence we, I think in time, as telepharmacy was available and we've been able to service really tiny hospitals, then, the accreditation standards have been raised a couple times since then. So now the practice of having a pharmacist review before medication goes to a patient is equivalent to the US. So that's we'd like to say our disruption as telepharmacy helped fuel that, and maybe that's taking too much credit, but certainly things are right now. There's a big boom in terms of implementation of your Meditech expanses and Epic hospitals, so CPOE and bedside med verification with pharmacist support 24/7 is growing quickly right now across the country. So, Sam, why don't you jump in?
Yeah, we've also seen a lot more here in Canada with pharmacy technician regulation. So a lot of pharmacy technicians are doing the full workflow of medication management from a drug distribution process. So we don't have too many pharmacists involved in product checking. And I think now the assumption is there's still quite a few states in the US that are still requiring pharmacists as doing a final check of product and don't have the full regulation. And I know there's a trend towards getting all pharmacy techs licensed and regulated, but that's something we've been really hands off from a drug distribution perspective. We also see on the retail side, we don't do any drug dispensing, but when we look at outpatient pharmacies located in hospitals, most hospitals have outsourced it, so they've contracted out independent pharmacies or chains to kind of own and operate that community pharmacy. And in Ontario, we're not like the US or other provinces where we have large health systems. So we don't have large health systems in Ontario. And so there's that missing piece, I think, where hospitals are missing out on how they can actually close the gap on providing more services for patients as they're being discharged. And that leads into transition of care where, we don't have too many meds to home type of programs where the health systems in the US will actually provide the drugs before the patient leaves. We're relying on prescriptions being written and sent out to the community pharmacies to fill. So that transition of care gap is something that we're lacking. And we still don't have a lot of pharmacists involved at discharge for medication reconciliation. And that's something that Kevin and I are both advocating quite a bit, as are a lot of the thought leaders in Canada.
Yeah, I really like that concept of using the technicians more for oversight of technical functions like sterile compounding. We've had the opportunity to work in a couple other Commonwealth countries, the UK and Australia, and they're really big on that there with, most of these sterile compounding operations oversight provided by a technician. So seems to make a lot of sense in freeing the pharmacists up for more clinical or direct patient care type work.
Absolutely.
The Northwest Telepharmacy itself is part of the Northwest Company. And, I find it really interesting that the Northwest Company is one of the longest continuing retail enterprises in the world. I think the company traces its roots back to 1779. And I know a lot of the locations in Northern Canada and Alaska have been in operation for well over 200 years. So tell us a little bit more about the Northwest Company itself.
Wow, Jim, we'd have a long podcast if we talked about the history of Northwest Company 200 years, but it's fascinating stuff. I'd love to talk for hours on this stuff because here it's, original fur trading company, not the original. In Canada, there's been, and the US, fur trade kind of opened up the country, and one of the first companies there was the Hudson Bay Company, and they were given an edict from Britain, British Isles, that all the land of the rivers that flow into Hudson Bay and James Bay were a monopoly for the Hudson Bay Company. And so, after that operated for over 100 years, the Northwest Company, banded together and said, you know what, this is a monopoly, but, we don't have to abide by it. And then some of the American fur traders coming up from the South and the Midwest, there was the West was kind of where the furs were. So the Northwest Company completely changed the model, put it on its head and said, well, we'll open, rather than the Hudson Bay model, which was bring all your furs to the coast and we'll ship them to England, is we'll put posts where the people are. And you can come trade your furs, closer to home. And we'll worry about getting it shipped where it's going to go to market. So, I try and draw those parallels a little bit between the fur trade and way back in 1779, where let's go to where the people are or where the hospitals need the work. So let's lessen the barriers of, little places that can't get a pharmacist at all when it's an extremely small place, or in the case of even large hospitals that are going 24 hours with their new Epic system, their after hours are underserviced. And, if using telepharmacy to extend that care through the night, then that's what we'll do. So, yeah.
And it's interesting that, back around 2004, 2005, that's when the North West Company also started realizing that the communities that they've been servicing from a retail perspective were lacking a lot of healthcare access, and so it was around that time where North West Company started looking to introduce more healthcare services and trying to kind of give back to the communities. And in 2006 they acquired the pharmacy through which Kevin was providing telepharmacy, and that was the first foray of into the pharmacy world, the retail pharmacy world, the community pharmacy world for North West Company. And now we have about 20 pharmacies in northern Saskatchewan, Manitoba, Ontario, as well as Northwest Territories and Nunavut as well. And so majority of these pharmacies are located in the actual Indigenous communities that we're servicing from a retail perspective. And our pharmacists are integral parts of that community. They're one of the few constants you'll see in healthcare in these communities. You'll have a lot of physicians and nurses that rotate through, but our pharmacists are really there 365 days a year, being part of the community, and partaking in a lot of the traditional events that are occurring. And as our company has expanded the healthcare region, we have a robust OTC type of business as well. And most recently, we've introduced a brand new division with opticals. And so, Nunavut, some of these residents of Nunavut territory are getting their eyes checked for the first time ever. And so they're getting prescription glasses now and getting checked to see if there's any, referrals needed for ophthalmologists to manage their eyesight. And so that's something really, really big that North West Company has been pushing for is to really expand as much more healthcare services in these communities.
That's excellent. And specific to your operations at North West Telepharmacy, tell us what you're doing there currently.
Yeah, our core business is really providing remote pharmacist services to hospitals, from managing small sites that don't have anyone on, any pharmacists on site, to supporting larger hospitals, meeting those 24/7 requirements in a CPOE world. We're facilitating the order review of medications, but also helping with pharmacy and therapeutics, formulary review, in servicing, and even a 24/7 drug info or on-call service that we have for hospitals to reach out to us. We've grown quite a bit. We're now about 250 pharmacists on the team. I think I was employee number 8 back in 2008. So it's grown quite a bit, and that's also led us to really expand how we're able to offer more for hospitals in other areas. So we do work in providing primary care work with clinics. So we have pharmacists getting referrals from physicians and nurse practitioners. We work with telehealth services and supporting medication-related questions after hours from patients, and then we're also helping with consultations and stuff that a lot of these hospitals have not been seen by pharmacists outside of the region. So when you have a new set of eyes coming in and providing recommendations on how to meet our sterile compounding standards, or understanding what impact the USP standards will have on our Canadian standards, that goes a long way to really make sure that these hospitals are staying up to date. So we've really been able to expand beyond just the core business of providing the hospital clinical services.
Yeah, I can imagine that for many of the remote areas you guys serve, it's pretty difficult for communities to attract full-time pharmacist support. What's the pharmacist labor market look like in Canada?
Yeah, it's certainly cyclical. Across the 20 years we've operated. Just looking at the past 4 years, start of COVID in 2020, and I think most, anyone who had a job was happy have a job. And the market then, we were still doing telepharmacy, but it was pretty stable. There were certainly hospitals that needed the help. There were hospitals that had overnight support that were going to keep that support. But then a little later on in the pandemic, when pharmacists were asked to do as much as they were and deal with medication shortages, burnout, opportunity to move into other fields that were maybe less stressful, there's been a real dip in, a decrease in the number of hospital pharmacists available. And there's always the push and pull between hospital and retail that can go on. So right now, there's certainly a demand for hospital pharmacists across the country. And, and then add to that all the hospitals that have sort of, might have delayed their plans to go CPOE and bedside med verification and 24-hour support. Suddenly, all those projects are back on the rails. So, it's a shortage of available people, and so certainly a demand for telepharmacy support is out there right now. So, and that can be rural places, but also urban locations we're finding. So,
speaking of CPOE, how do you guys handle the differences in IT technology and all the different operating processes across your client sites?
Yeah, that's one of our big challenges of not having standardization occurring across all the hospitals. So, with multiple instances of Epic, Cerner, and Meditech Expanse, and that we have to deal with, it's been one of the the barriers of being able to quickly get something going within 24 hours. And to be honest, we have been able to launch hospitals within 24 hours in the past. It's not what we always like to do, but sometimes when push comes to shove, we're willing to kind of bend backwards to help out with some of the hospitals. So we really have changed our approach over the years. At one point we would have a pharmacist covering 7 or 8 hospitals with different IT systems in place in terms of their systems. But as we grew, we really realized that we need to kind of manage our staff in a way that they can feel comfortable, not having to really jump from one system to another. So we have a nice approach where we have a team of pharmacists that really focus on Meditech hospitals, a team of pharmacists focusing on Epic hospitals. We still require the pharmacist to kind of spend a few months really learning this hospital systems until they get comfortable with it. So that way, they're not still green with those sites. But it's a nimble team, quick learners, and I think that's been pretty good with our staff, that they are tech savvy and able to really take their learnings from their previous workplaces and kind of introduce it and apply it to their new sites. We have introduced some technologies. We did implement a software called PowerGrid RX, which is used in the US by Pipeline RX, and that's allowed us to kind of really centralize our queue system for orders. So it doesn't matter which hospital we're covering or which system they're using. We can really see in a central queue where all those orders are coming in. So that really streamlines our approach of having to teach our staff how to use one system versus every hospital having their own system. And so a good chunk of our hospitals are leveraging PowerGrid in that process. We've also just started working with Hypercare, which is a messaging app, and that allows us to communicate with hospital staff and our team a lot more efficiently and just really using one platform versus having to go out and learn 5 or 6 platforms. So different strategies we're doing, including even with BPMH, or Best Possible Medical History. We're working on a tool right now, which I can talk about later, on how we're collecting information, so that way we can standardize the process, regardless of which hospital we're covering. And BPMH is, as you know, even in the US, every hospital does it differently on what software they're using, what workflow the pharmacy techs or pharmacists might be involved, if nurses are involved. So we're trying to standardize that, so it doesn't matter which hospital is leveraging our services. We'll have the same process when it comes to that service.
How do you handle setting up services? I would imagine for some of these really remote sites, it's not exactly convenient to hop on a plane to get to a location in the Northwest Territories or Nunavut.
Yeah, so we have some pretty remote ones for sure. Our first telepharmacy client in 2004, that Winnebago hospital I talked about in Moose Factory, it's you can fly to it. There are commercial flights that are often delayed due to weather or otherwise. You can take a train there. Once you've driven to Cochrane in Northern Ontario, there's a 5-hour train into Moose Factory or Moosonee. Moose Factory's on an island close to Moosonee, so you're either taking a boat or driving on a winter road to there. Or there's also winter road, only there when the ice freezes all the way up the coast from there. So there are actually 4 communities that are fly in the summer, year round, but they're also winter road, which brings in some of their dry goods. So yeah, pretty remote stuff. But I think that's what's interesting to all of us, and feels like a bit of adventure where you might be sitting in your home in small town or somewhere in southern Ontario and be servicing somewhere cold and remote. So
yeah, for our listeners that don't experience winter, when you say winter roads, that's typically a road plowed over a lake.
Correct, lake, and in the case of Northern Ontario, it's muskeg. So it's boggy land that otherwise you'd sink in and lose a vehicle in there. But with a good set of cold weather, -40 is where Celsius and Fahrenheit are the same, and they see it at times. So actually, there's a lot of concern with global warming right now that some of the winter roads are open later and closed sooner. And that's important even for bringing food into a lot of these communities. They'll bring a lot of the dry goods in on the winter roads once they're ready. And Northwest Company that's kind of we're a little different. We're the healthcare side of Northwest Company, but that's a huge part of the main business, which is bringing groceries, bringing snowmobiles, bringing furniture, anything that people need to the remote communities. So.
Any particularly fun or unique stories from those sites you can share?
Oh, we've got lots of stories for sure. I'll give you a couple. Actually, this was actually from my years of working in Moose Factory. When I finished my residency, and at that point, there was no chemo hood in the hospital, but new pharmacist in town, and this is pre, heavy USP standards, or in Canada we've got NAPRA standards. It's kind of the USP 797 equivalent or 800. But, there was an opportunity, someone needed chemotherapy. So I searched the hospital there, and it was an original TB sanatorium in the tuberculosis heyday. And so I found a hood down in the dental unit, and certainly not sterile, but I'd clean that up when someone needed chemotherapy and mix my products up there. At least it was protecting me. But I found the hood would actually pull outside air down and in the hood. So it was a vertical flow hood appropriately, but I'd actually get a little bit of frostbite on the tips of my ears, or feel like it anyways, when it was pulling -30 air in and, right past me. So, but people could get chemo, and now the standards are a little bit too high to it's possible, but they're planning a new hospital in Moose Factory. So it's in the planning stages now. So that will include sterile compounding and hazardous sterile compounding in the future once that hospital gets built. But the other one from Moose Factory in the early days of telepharmacy was a young girl who had a brain tumor and had that, excised surgically in Children's Hospital, in the Sick Kids Hospital in Toronto. So you can imagine someone who lives in very, very remote Northern Ontario, where their whole community is, in downtown Toronto in recovery, and then ongoing chemotherapy every 2 weeks for the rest of her life. And she'd quite early been told that there would be no availability to mix chemo in her hometown or get it there. So it took a little bit of research, but we did find that, the stability's there for this product for 2 weeks. So why don't we, a little over 2 weeks. So we actually could get, 2 doses mixed up for, her the dose and get a dose arrive in the community the day before it was given, and also the dose for the next week as well. So, it's sort of really, highlighted how telepharmacy can improve care for people. So that instead of living in downtown Toronto, away from family, other than maybe parents, she was home with her siblings, with family, out on boating trips, and able to, have quality of life and still get the life-saving treatment that she needed. So.
Excellent. That's tremendous. Thanks. We have individual state boards of pharmacy in the U.S. that regulate pharmacy practice. And, of course, you deal with provincial oversight in Canada. What challenges does that present?
That's a great question, because we've had to deal with quite a few of similar challenges that you would have with the state boards needing, pharmacists to be licensed in each state, especially in the telepharmacy landscape. So with each province really kind of having their own regulatory oversight or none of hospitals. Some sites will some provinces will need us to get licensed in each province. Others will as long it won't really be focusing on residing in the province, but need to be licensed. So there's a lot of mishmash of stuff. And what we've really been working on is the cross-jurisdictional piece, so advocating for that. And what's really nice is that there's finally a consensus amongst all of the regulatory bodies in Canada that cross-jurisdictional services needs to happen, especially with specialty pharmacy occurring, where you might have a pharmacy that's or a wholesaler that's providing some of the specialty pharmacy meds from one side of the country to the other. So that type of oversight is where we're starting to see a loosening up. We're hoping within the next 4 to 5 years, each of the regulatory bodies will have their statements on how a pharmacist licensed in one province can provide services in another province without having to go through all the rigors and hoops that we do today in order to get licensed in those provinces. So that should make it a little more easier for our team to be able to cover more sites, because we do have pharmacists that are licensed in 3 to 4 provinces. No difference than in the US, where some pharmacists are licensed in like 15 states in order to do their telepharmacy world. But it's a lot of cost and inefficiency, I think, when you're needing that type of oversight for telepharmacy space.
With Canada being bilingual, anything special you have to do for La Belle Province if you're doing work in Quebec?
Well, really good question. We do have a bilingual team. Not everybody on the team is bilingual, but we do have, like, say, for on-call services, where it's sort of our overnight light, we'll call it, where they're still not processing orders throughout the night, but do need that pharmacist support for clinical questions or maybe medication supply, deciding what can wait till the next morning or what does need to be obtained, or even if it's from a hospital in a community close by. So that one does have a bilingual team that can answer in English or French for people calling. And then certainly some hospitals are French speaking hospitals. So again, we'll have our bilingual pharmacists on that one. So we can manage those hires though, for sure.
In a single payer system like Canada, it seems funding's always a challenge. How does that impact your work?
Yeah, I'm not necessarily sure. Funding's always a challenge. As in, certainly there's advantages of the U.S. Private system versus a public paying system, but it all comes down to a business case, right? So if you can, make a business case that, an improvement in services improves patient care or improves, efficiency somehow, there might be a bit more bureaucracy to make that change, but and possibly delays as a result. But the right business case, usually they'll follow the right route of making it sure that it's pharmacy innovations and changes are approved. So, Sammu, do you have anything to add to that?
No, I think you're bang on. It's just, so there may be delays in getting the funding or the budget approved for the services or technologies that we want. Like an IV workflow solutions is an example where, Kevin and I have been pushing IV workflow solutions since 2015, 2016, and the dollars to spend on that are just starting to open up over the last several years. And that's just, just just how things are, and sometimes in Canada where we are a few years back, and it takes 3 to 4 years of planning to get the budget set aside. And the nice thing with how Kevin and I have really looked at supporting some of our smaller hospitals when we're introducing technologies is really looking at it from a taxpayer perspective. In the end, Kevin and I pay our taxes, and those taxes are what's funding the hospitals. And so we want to make sure that the dollars spent are done responsibly. And so, we've taken extra steps to kind of look for those type of technologies or solutions that can be cost effective, that would not only benefit the patients, but also the hospital and, of course, our health system, which is under a lot of pressure these days when it comes to not having enough dollars to keep expanding.
Outside of provincial regulation and funding, what are some of the most interesting challenges or opportunities that you have to address in your work?
Yeah, I mean, I think for me, the big excitement is just making things work, and whatever challenge comes up. We've always positioned telepharmacy as, though we're not there in person, we'll do whatever we can to match, what a pharmacist on site would do. I mean, we would never tell a hospital, don't have an on-site pharmacist. If you have the opportunity, absolutely, that, there's still a human contact there, but we'll design telepharmacy in the best way possible to provide all the care that people can have. So, we started in hospitals that hadn't had a pharmacist walk through the doors into the hospital or into the pharmacy in over 10 years, maybe never. And now, with 250 pharmacists on staff, we were able to at least provide all the benefits of a pharmacist. It's also interesting to hire 250 people that maybe had history and learned a bit about the North and First Nations, but really don't have a good, exposure to that, suddenly now have opportunities to maybe travel to the North, because we do have, when they have a real need, either in a hospital somewhere or in our retail stores, there's an opportunity for people to learn about and potentially travel to remote places, and they just love that opportunity. So, and just seeing the challenges and what the North faces on a daily basis that you wouldn't necessarily think of in your practice in downtown Ottawa or Toronto.
Yeah, maybe picking up on that just a little bit more. I know you're always looking for new and better ways to deliver those remote services. Anything in that area you can share that you're working on?
Yeah, and I know when we first thought about innovation, we started introducing telepresence robots to kind of give ourselves some of that in-presence, our on-site presence. But most recently, what we're kind of really excited about is working with a developer and a company called First History, where we're actually developing a BPMH, or best possible medication history data collection tool. And so right now it's intuitive in the sense that it really standardizes the approach, how questions are asked and how the information is collected. And so we have a remote pharmacy tech-led program. They're leveraging this software that is in the second or third iteration of its phase. And it's really changing the way how technicians are asking questions. So, generally it takes about 45 to 50 minutes to really do a BPMH. And then the pharmacist has to do their med rec, and they might have to go back and ask questions based on the medication list that was compiled. And so we're building this algorithm within the software. That way, if a patient happens to be on a diabetic medication, a pharmacist normally would ask, what are your sugars in the morning, or have you had a low recently? Questions that pharmacy technicians are not really asking when they're doing just a collection of list of medications. So we're incorporating a lot of clinical questions that we're getting the pharmacy techs to ask, which then help kind of reduce the time that a pharmacist would need to go back and ask those questions. But it will now help a pharmacist, physician, nurse practitioner in assessing the medication from a med rec point of view. And the end goal is to actually hand this tool to the patients while they're in the emerge department. So our patients are already spending 6 to 8 to 12 hours in the emerge department. So why not get them engaged, have them spend a couple of hours completing this form as best to their ability, maybe contacting a pharmacy themselves. or even getting their caregivers to help fill out that BPMH list and answer questions that can then be used once they get into a room in the emerge and their physician seeing them. And it can be applied for pre-op clinic appointments, etc. as well. You can just send a link to their home and they can fill it out before they even come into the pharmacy, or into the hospital. So that's our new thing that we're working on. We just piloted for 6 weeks at one hospital, and we're expanding that, and that will be available for all hospitals across Canada, as even leveraging it for their own staff to use.
That's a nice step up. We could probably keep going, but I want to be respectful of your time. So finally, I have two very important questions. The last time a Canadian team won the Stanley Cup was 1993. Is this the year the streak gets broken and the cup comes back to Canada? And is everyone in Canada now an Edmonton's Oilers fan?
All I heard on the start of the last series, there was a scene will be leaning more towards the Canucks there. I don't know. I'll have to let Sammu answer, though. He's better up on the hockey sports. Yeah.
Well, we're down to one, and it'll be interesting to see how many Torontonians start supporting another Canadian team to win the Stanley Cup. Hopefully the Oilers can bring it back, but as a Torontonian, we're hoping next year Toronto wins the Stanley Cup as the first Canadian since 1993.
A really interesting session today, and thanks guys for being on the podcast, and thanks for everything you do to bring pharmacy services and support to people and programs that really might not otherwise be able to obtain that care.